extension of the calf, you have toe elevation, weight transfer maneuver and dependency maneuver, and we'll go quickly through it. But you know that Valsalva is very difficult because patients make this like instead of pushing, and there is no anterograde flow before the reflux or retrograde flow. And so Franceschi and De Frate developed a variation which is just taking a straw, doubling it, and making the patient to blow inside of the straw. So it is always the same pressure. He doesn't faint because some patients, and then suddenly they faint. And if you just take a straw, this is a very good idea to have a Valsalva longer lasting instead even. And this is a very good idea in my opinion. Manual compression and decompression of the calf, everybody of you knows it, it is very widely used. No participation of the patient is needed, it's important thing, and it can be repeated and repeated and repeated, but what you provoke is no physiologic flow, and sometimes it is painful for the patient. If he has pain in the calf, it can be painful. And I have very little hands, and if you have a large man or woman, you can, it depends on the power you have and so on. So there are some problems. This is my daughter's hand and my husband's leg, and so you very easily see it can be a problem of reliability depending on who is doing the investigation. Then the first functional measurement was done by Franceschi in Paraná, which is pushing the patient taking him to you, which is a physiologic flow because the patient contracts the calf. But this is not endlessly repeatable because the patients become aware that they will be pushed and they become rigid. And I do investigate my patients like a little bit up and they are afraid to fall down. So I thought that I should develop something else. And so when I came back from Paraná learning this maneuver, I called it Wunstorf maneuver because I live in Wunstorf and I think personal names are not so important. And this is just elevating the toe. So we will see a movie just afterwards. If you elevate the toe or contract the digits of the foot, you have a calf contraction. Patients used to understand this. And here you see from a video from German society, look at the toe, it goes up and there is a flow, it goes down and there is a reflux. It goes up, little flow, goes down, large reflux. You move large volume of blood just moving the toe. Here is again, toe high, reflux. And if the vein is healthy, like we move the a little bit below, toe up, it's a flow, and then no reflux. So just by saying elevate the toe or making a sign, you can organize a good flow in the vein. And then simultaneously in England and in Germany, Mr. Latimer and me came across a so-called dependency maneuver, which sometimes you have a patient with varicose veins, and it's obvious that there are varicose veins, but there is no flow like this. You have compression, decompression, and you say, the vein is tiny, okay, but there should be more reflux. So you put the patient lying down, the leg up to the air, 20 seconds. This one was very sportive, but you can also help. And then stand up again. And this is the same lady with this little flow you saw before. And this is a large filling flow of this vein. My theory is some veins have a little of capacity to change diameter. And when she's full, the vein, there is no large volume moving. So this is just standing manual compression, decompression. This is dependency maneuver after 20 seconds lying down and standing up again. And you see, if you look at this, there is a video again of this thing. In German it's called Autostase. This lady had very little flow here, so I put her lying down. And we waited 20 seconds, there is a cut in the movie, and she stands up again. Then it takes a little time to find the proper place, but the reflux duration was defined by Nikos Apropoulos, who measured healthy persons, and he saw all the healthy persons had a reflux duration, this little bit back of less than 0.5. But he did not measure patients. So we assumed that a reflux lasting longer than 0.5 would be a reflux of a patient. But I think, I claim, and lots of people are coming behind or coming independently, that we should claim for 1 second at least reflux duration to call it a ill vein. We made a little study in my office with 53 legs included doing manual compression and toe elevation, 40 with clinical signs of venous insufficiency and 30 without. And we did an examination of the reflux duration and took the obvious one, lasting longer than 0.5, were considered as pathological. And most of them, this one is always 1 second, 0.5, 0.5, and most of them, the reflux duration is far longer than one of these distances. And when we made, this was the reflux length in seconds in the Mustafa maneuver and the reflux length in seconds for the manual compression, we had a real high correlation between them. But still, we found this one were the healthy ones, the red ones were the refluxive one. We found only one patient with 0.5, less 0.5 in Mustafa maneuver, but more than 2 seconds in manual compression. So the second information was that there were people with one maneuver, no reflux, with the other one, a really significant reflux. So I invite you at the proximal thigh always to do 2 maneuvers, 2 different ones, to be really sure that you are not missing the pathological ones. And if you see there were very little of them outside below the 1 second, but all of them in the other maneuver had more than 1 second. So I claim for please consider 1 second, because at least in Germany we are over-treating patients with healthy veins if you take the cutoff of 0.5. So which pitfalls can we have in this to provocate a flow? Manual compression can be a problem with pain or the hand size. Toe elevation can be they have muscular disorders, people with Parkinson, for example, or people with back pain and muscular disorders in the leg. Weight transfer, which is like this, I took it out, is also people just with equilibrium problems can't do it. Vascular, lots of them can't blow into can't make the properly. But the dependency maneuver has no pitfalls. The system goes empty if you pull the leg up, and the system refills independently of anything that could make an error. If I find some time and stop making congresses, perhaps I can do an investigation comparing all 4 most used maneuvers and comparing them to the one without pitfalls, because normally we used to compare it to Valsalva, but Valsalva not always works, and so on. So I think we have to correlate them to the dependency maneuver. So having said this to the provocation maneuvers, we go on to the great saphenous vein, which you know runs from the ankle, because anatomically it runs from the ankle to the groin, even though we always start looking in the groin because the reflux starts above. The saphenofemoral junction is the most important place we will always be looking at, and the most of the illnesses we will treat is there. The great saphenous vein drains into the common femoral drain in the groin Cs, and it collects tributaries, 2 accessory veins, the anterior and the posterior, epigastric vein, pudendal vein, circumflex vein. And altogether they are called the tributaries of the groin, or a vein star, because they make like a star radially. So this is a very ancient, but I love it, image. This is the saphenous vein, artery, deep femoral, common femoral vein. You have the epigastric veins, the accessory laterals, as it was used in that days, the anterior, and you see pudendal veins. This one is the ostium, the place where the fascia is broken to allow the vein to go through it. And this one, all this region is called the saphenofemoral junction. And I'm very sad in the anatomy consensus document by Kajati et al. In 2001, they forgot about to exactly define what is the junction between the terminal and the preterminal valve, between the ostium and the preterminal valve. This was not defined, but we are comprehending that we are talking about this region when we talk about the saphenofemoral junction. The flow in saphenofemoral junction under normal conditions is from the saphenous vein to the deep vein. Of course, we are measuring a standing position with valsalva or cremona, manual compression of the calf, and toe elevation, and in case we have only little flow dependency maneuver. The questions: is there a spontaneous flow? Is there a reflux? And which is the origin of the flow? Spontaneous flow you will find very seldomly, but this has to alert you. Normally, if the person is standing and you put your device and start the duplex, the color, nothing happens until you do something. But in some patients, there is a permanent blue antegrade flow. And this has to alert you because this means that there is a deep vein thrombosis. If you have a thrombosis, the great saphenous vein will be the bypass for the deep vein. And so you will find a large vein with a permanent flow. And don't think, oh, this is ill, I have to take the vein also. No, you have to be aware that this means there is a deep vein closure or reflux, and this flow is bypassing the deep vein. So after having seen the correct flow, the most common flow you will find in pathology comes from the deep vein, through the ostium, into the great saphenous vein, and down the great saphenous vein. This is the most often seen flow in patients with chronic venous disease. This is a schematic representation which I will use. The deep vein, the terminal valve, and the preterminal valve. Let's go back. Terminal, the preterminal valve, and the cranial accessory, the epigastric and circumflex vein, and the accessory anterior. The pudendal vein is no image because it would cross here, and I did take it out. So I don't know if the movie will run. No, the media wasn't found. We can see the valves in the groin, sometimes very, very wonderfully, like this and this, but it is not always to be seen. Even though we don't see them, they are there because otherwise the vein wouldn't be competent. And the terminal valve is defined as within the first 1 centimeter of the deep vein distance. Here is a little one terminal, and the preterminal valve is almost around 2 centimeters from the deep vein. And depending on the flow at the saphenofemoral junction, we can classify the patients. No reflux, both valves are competent. Reflux from the deep vein, the terminal valve is competent, and this is called axial reflux because it comes from the deep axis to the superficial one, and normally it is responsible for large blood flow reflux volumes. And then we can reflux from the and the terminal valve is competent. We can have tributaries of the groin, proximal perforating vein, and then entering the great saphenous vein deeper. We will go through these cases. We have a reflux from the deep femoral vein, from common femoral vein through both valves. Both are not competent into the great saphenous vein. This, I will come to this Zollmann group again later, is 52% of cases in a collective of 2,000 persons getting operated on their veins. Then have this situation. And if you say the truth, if you think of varicose veins, I think you think only of those because you think they are by far the most common. But if you analyze this exactly, this situation, just from the deep vein through these two valves below down the great saphenous vein, it's only half of them. How do we measure it? To document it, we have to go in the ostium, just here, not somewhere, just here, and have an anterograde flow and reflux in diastole. This is a classical axial reflux into the great saphenous vein. When we take it longitudinally, we see in diastole, we have pressed the calf, or we have elevated the toe. We have an anterograde blue flow into the deep vein, and in diastole, when we relax the patient, there is from the deep vein a red color going out into the superficial vein. This is a classical axial reflux with a broken terminal valve. Sometimes people ask me, but if here in the deep vein is a reflux, this means that the person has a deep vein pathology. And when I read some publications, I think, I understand that everybody is keen on stenting and doing things on the deep veins. But if you have a reflux here, in the standing person above An incompetent great saphenous vein, the blood doesn't come from somewhere, it comes from the deep vein, because it has to empty here. And here you have a low pressure vein. And of course it comes from the deep vein filling the superficial one. This doesn't mean that the deep vein is incompetent. The deep vein is the reservoir filling the superficial one. But if you see a reflux in the superficial one, the blood has to come from somewhere. And this is the deep vein. This doesn't mean that the deep vein is incompetent. It is incompetent if you have a reflux here, above the next valve or below the saphenofemoral junction. This is the physiological outflow from the deep vein. So the diastole, which is the relaxation phase, terminal valve and preterminal valve are incompetent. We have an axial reflux or ostial reflux, like Spanish and French people like to say. But we have other possibilities of reflux. It can be starting from the epigastric veins, from the pudendal veins, or even from the accessory vein into the saphenous vein with a competent terminal valve, like you see here. We have a competent terminal valve and still a reflux in the GSV. And if you look at this Solman study, I told you these are 20% of the patients. 1 of 5 of patients you will treat have a competent terminal valve. And I think this is an important thing to have to consider because, I mean, this evening I will talk a little bit about what this could mean, but if you consider that treating endoluminally till this place, you will close all the pathological pathways. And I would love it that studies doing endoluminal treatment would consider the terminal valve competence before making the study, because afterwards this reflux drains to the deep vein and there is no high pressure forcing a recurrence. But we don't still include this knowledge into our studies, even though terminal valve and preterminal valve are known since 2006. They're published, Stücker types are published since 2010, but still it didn't arrive the heads of the investigation. You see the deep vein from the deep vein. So please always have the option in eye when you investigate the saphenofemoral junction to make errors. This was a systole, wonderful anterograde flow, and in the initial there is a speed flow coming out from the pudendal vein, not from the deep vein. Another one, this is a reflux from the epigastric and the pudendal vein, both of them. We have another possibility. We can have an axial reflux escaping the accessory anterior vein. This is easy to be identified because clinically the visible veins are on the and only a retrograde flow through in the diastole. You can use the alignment sign to distinguish both veins. You can imagine at the medial aspect of the common femoral vein a line, and all veins medially to it are the saphenous vein, and all the veins laterally to it are the accessory vein. This doesn't work always, but it is a good rule to differentiate. My other way to do it is put the probe on the proximal thigh and follow the vein up, because the vein you will meet here at this place is always the great saphenous vein, and if you follow this up, you will find out at the groin place which one is which. This is another example where you see it is difficult to have both in one image, so I always use the same ones. This is the groin Cs. You have the reflux here, and if you go a little bit down in the same patient, you have in systole the below anterograde flow in the great saphenous vein, and the reflux in the accessory vein. So let's come back to this reflux situation. Reflux from the common femoral vein with terminal valve incompetent is 66%, but only 52 are just from the deep vein to the great saphenous vein. Others are also into the accessory anterior or accessory posterior vein. Both, you have a reflux from the deep vein and from a tributary are in 8.54%. Cranial reflux are in 21%, so 1 of 5 of the patients, and this is a large number. In more details on this classification from this group from Germany, I will talk about it sorry, short after 2 today. So just a reminder, when we have, this is a competent situation, if we have a reflux in the great saphenous vein, we have to know at the end of the exploration which is the origin of the reflux. This means from the deep vein, like I've shown, measurement in the ostium. This is just the place where you have to measure to be sure this comes from the deep vein. Or paraosteal reflux from a groin tributary, you have to define it and you have to describe it. Again, an image, systole, you have an anterograde flow, and diastole, this comes from the epigastric vein. Here you see the terminal valve, here is no flow. This is very important as a take-home message. This is another case, which a large epigastric vein, systole is in blue, perfect, diastole, no reflux from the deep vein, but from the paraosteal, from the epigastric vein, and in cross-section you see it from here. This is a differentiation between both. This is a large saphenofemoral junction with a large reflux, and this is a not so large junction because the reflux comes from the epigastric vein. Also in Valsalva we can measure this. We can put the probe just inside the ostium, and during Valsalva we will have no flow, but after Valsalva we will have a large inflow because the blood going into the saphenous vein from the pudenda, for example, now will empty into the deep vein. But doing Valsalva with this differentiation is difficult because and this is the Egyptian eye. Yes, I have the Egyptian eye in your representation of your meeting, but this is the saphenous vein. The normal, the great saphenous vein is between the muscles. Fascia saphena was known 1800s, but was forgotten. And it was Alberto Caggiati and Stefano Ricci who gave it importance again in 1980 somewhat, and this ended up to the consensus document in 2001. This is why the saphenous vein will never be meandering or tortuous. If somebody says we have a great saphenous vein varicosity, I say varicosity in my eyes is never seen in 25 years a meandering great saphenous vein, because inside the fascia shade it is impossible. And if it were meandering a lot, I mean sometimes it is so large that it makes like a little curve, but you always can pass the stripper or the laser device through it. If it was meandering, you couldn't. Coming to the groin, the fascia compartment goes broader, so sometimes the accessory anterior or posterior runs inside the same fascial compartment. And this is the eye, I mean now I have two eyes, the eye and the eyelid, and this is the saphenous fascia. And you can have three important different paths of the brain in the leg. It can run inside the fascia